Guys, you're watching the Best Practices Show, where we take a look at the best business practices from the best dental practices all across the country. And today I've got one of the world's top restorative dentists on today. We're going to talk about the 6 tools to help you put the teeth in the middle of the smile with Dr. Bill Robbins. So don't miss this. Do me a favor, grab a pen and hit the share button. We'll see you in a second. Hey guys, you're watching the Best Practices Show. Thank you so much for watching. And today I've got a very special edition with one of my favorite people in all of dentistry, Dr. Bill Robbins. And you are going to love this. This guy is fantastic, and you'll see why here in just a second. But a couple show notes. We are shooting this live. So as you're watching this, if you have questions, add them to the feed directly, and I'll ask Dr. Robbins directly, and we'll get the answer straight from the expert himself. And then also, if you're watching these later on, which a lot of people do, feel free to add questions to the feed, and we'll make sure you get the answers that you're looking for, because we want you to get the most out of this. Now, my guest today, it always takes me a while to get him on because he's a busy guy. He's got a lot going on. One of my favorite mentors in dentistry. Just super, super cool guy, Dr. Bill Robbins. And you and I got a chance to meet each other years ago in the Seattle Study Club Symposium. We see each other out speaking. If people haven't heard of you or haven't seen you, who's Dr. Bill Robbins?
Just a country boy from San Antonio. I'm full-time private practice. I spent the first 25 years of my career in academics. So I was primarily a teacher, and I ran AGD and GPR programs. And then after 25 years, I decided to try the great frontier of private practice, and that's where I've been for the last 20 years. So I'm a guy making a living doing dentistry, just like everybody listening to this show.
Yeah, and he's a great teacher, runs some great courses. We'll talk about him in a little bit. And one of the pioneers behind the core diagnosis and global diagnosis, and you developed a system. Now, you developed the 4, 5, 6 system. We're going to talk about that, but tell us why this is so important to have tools to put the teeth in the middle of the smile. Like, why is this such a hot topic? Okay, so I mentioned this earlier, and I always want to start out saying this. The 2 people that are really responsible for facially generated diagnosis, as most everybody knows, are John Coys and Frank Spear. And so I always want to give those guys credit because they've both had a giant impact on the way I view the dental world and certainly the way I view facial diagnosis. So I became a devotee of both of those guys many years ago when they first started teaching facially generated diagnosis, and it made so much sense to me. And at that point in my career, I was practicing with my good friend Jeff Rouse, who also practices here in San Antonio. He's a prosthodontist. And we developed a teaching partnership, and Jeff and I have worked together for the last 20 years on this whole concept of global diagnosis. And it is not to take the place of facially generated diagnosis of Coys and Spear. It's to add on top of it to, I think, make it better. Mm-hmm. The emphasis in our global diagnosis system is based on the gingiva. And it's our belief that if the gingiva is in the wrong place in the patient's face, then that patient defaults to an interdisciplinary patient. In other words, I cannot fix that patient as a restorative dentist. I'm going to have the help of my specialist. And so the whole emphasis in the global diagnosis system is figuring out why the gingiva is in the wrong place. Once we name the problem, then it's easy to treatment plan it. So there are 4 global diagnoses that Jeff and I talk about. The first is related to a skeletal discrepancy. The second is related to a short or hyperactive upper lip. The third is related to the gingival line in relation to horizon. And when that's not correct, we term that dentoalveolar extrusion. That means the teeth have super erupted and they've gone into places that are no longer correct to work with. So essentially, the dentoalveolar extrusion patient is the wear patient. And the fourth and final global diagnosis is related to gingival coverage of the necks of the teeth, which we all know is called altered passive eruption. So those are the 4 reasons that the teeth and gingiva cannot be working in concert in the patient's face.
It turns out that we only have to ask 5 questions to make a global diagnosis on any patient. The first question is, and when I'm talking about skeletal discrepancy, obviously I'm interested in other than vertical skeletal discrepancies, but this is sort of an overview today. And the skeletal discrepancy that impacts me the most as a restorative dentist is vertical maxillary excess. So the first question is related to face height, where we're measuring the middle third and the lower third. The second question is lip length and mobility. And we remember that the average lip length in the young female, the 25-year-old female, is 20 to 22 millimeters, and in the young male, 2 millimeters longer. And we also remember that the average lip mobility from repose to full smile is 6 to 8 millimeters. So the second question is related to lip length and lip mobility. The third question is the gingival line, and we look straight at the patient and we determine if their gingival line is parallel to horizon. If teeth have worn and super erupted, then they're going to bring the gingiva with them, and we're going to have that characteristic concave gingival line rather than the straight gingival line. We see it most often in the front teeth, maxillary anterior teeth, but it can happen anywhere in the head. It can be the upper jaw, the lower jaw, the front teeth, and the back teeth. So essentially, we're looking for the relationship of the gingival level, which is supposed to be parallel to horizon, in relation to where it is in the patient's head. And if it's curved or concave down, then that means teeth have moved and the gingiva have moved into the incorrect positions. So that is the third question. The fourth question is the measurement of the maxillary central incisor. We all are familiar with that. The average central is 10 to 11 millimeters long. And if it's short, there's only 3 reasons the central incisor can be short. The first is microdontia. It's just that God made them small and they're little teeth. The second is incisal edge wear, and we all know how to evaluate incisal edge wear. And the third is altered passive eruption, and that's where the gingiva is covering the necks of the teeth. So how do we determine if the patient has altered passive eruption? We ask the 5th question, and that is, can you feel the cemento-enamel junction in the sulcus? In the normal attachment apparatus, you can feel the CEJ. In the patient with altered passive eruption, you can't. So a patient that has altered passive eruption has teeth that are short by measurement, and you cannot feel the CEJ in the sulcus. So what we've quickly gone over, Kurt, is the 4 global diagnoses and the 5 questions that lead the clinician to the global diagnosis or diagnoses in a given patient. So that brings us to our subject today.
Yeah, which is the 6 tools. Now, where did all the tools, you've seen all of these patterns for many years, and you basically came down, there's 6 tools to fix it. What was the thinking behind this? I mean, how did this all come together?
This whole concept of 4, 5, 6 came together with a lot of teaching and learning between Jeff Rouse and I. Jeff and I started off as students of many people, Jerry Cheesh and Pat Allen and Frank Spear and John Coyce. So we traveled to learn from these guys, and then we started to try to implement the things that we were learning. And as we were implementing these things, we started to develop a system. We've got a form that we use to lead us through this process. And so we were first developing this system for ourselves so that we could better quantify and understand what the masters were teaching us. And ultimately, the system came through just the process of working with the information and using it clinically in our practices. So the 4, 5, 6 component of this is essentially stuff that just came out of our heads through the years as we were doing clinical dentistry and learning from the masters.
Yeah. Well, it's good because you always giving back. I love it, and helping all of us. But take us through this. So, when you see, and really, I want to add some perspective to this too. One thing I love about you is you're you're an amazing dentist, but you're also very real. And I asked you this last time, you're not seeing full mouth rehabs every single day. These are simple tools that you help create predictable, great restorative dentistry. Can you give us some perspective just on your practice? Like, I love how you describe that.
Yeah, I have the opportunity to speak to lots of study clubs, and most study clubs are made up of a bunch of general dentists and a few specialists. And so I obviously love being around the specialists because those are the ones that I've learned so much from. But I really love being around my compadres, my general dentist buddies. And I always, when I'm standing up in front of a group of general dentists speaking, I always enjoy telling the whole crowd that in my practice, I have a standard restorative dentistry practice in San Antonio. I see everything from CEOs to people that ride the bus to my office. And somewhere between 80 and 85% of what I do is simple dentistry. It's day in and day out, restorations, 1 or 2 crowns here, 2 or 3 crowns there. That's what I do day in and day out. And essentially, that's how I make my living. But that's not the part that really gets my juices flowing. I don't really have to do another single crown on a tooth to feel complete as a dentist. What really still keeps me excited about dentistry is that interdisciplinary patient that I get to treat. And so that's only maybe 15, no more than 20% of my practice, but that's the part that I love to do. So most of the time I'm doing regular restorative dentistry, but when the patient comes in that has interdisciplinary needs, we now have it on the shelf to give it to them. That's the fun part.
That's awesome. That's awesome. So take us through the 6 tools. Where would I start?
Okay, once again, I'm a pretty simple thinker. I'm fairly linear in my thinking. And so that's the way that Jeff and I thought when we were putting together this whole systematic approach. And as we worked through these cases, it became clear to us that there's just not that many tools that we have in our toolbox to fix these patients whose teeth and or gingiva is in the wrong place. So the first 2 tools are the perio tools, and that's either adding or subtracting tissue. So the first tool is crown lengthening, and that's subtracting tissue. That would be in the patient that needed either functional or aesthetic crown lengthening. The second perio tool is adding tissue, and that would be for the patient that has gingival recession and needs grafting done. So the first 2 tools are either adding tissue, which is grafting, or subtracting tissue, which is crown lengthening. Those are the 2 perio tools. The second 2 tools are the ortho tools. And those are the 2 that have become so important in our practice in the last 10 to 12 years. The first ortho tool is to intrude teeth orthodontically that have super erupted. And in the interdisciplinary patients that I treat today, when they're going to the orthodontist, essentially 100% of the interdisciplinary patients that I refer to the orthodontist, intrusion is going to be part of the prescription that I'm going to ask from the orthodontist. So the third tool is orthodontic intrusion. The fourth tool is orthodontic extrusion. Remember, we're moving the teeth in order to move the gingiva. I mean, it's important for the teeth to be in the right place, but we're also being told why the teeth are in the wrong place by the positions of the gingiva. Extruding or erupting teeth orthodontically is easy, and we've all been doing that for years. Intruding teeth orthodontically is difficult, and it's been one of those things that we could only do in maxillary and mandibular anterior teeth up until the last few years because there wasn't enough anchorage to intrude posterior teeth with just natural anchorage of the other teeth in the arch. So we were limited up until 10 or 12 years ago, we were limited to intruding anterior teeth. So Jeff and I have had our orthodontist intruding anterior teeth now for 25 years. My oldest intrusion case is 25 years old. As a matter of fact, I saw him today.
That's awesome.
His mouth is not in beautiful shape, by the way, because he only comes every 3 or 4 years when he needs to have his teeth brushed by the hygienist. But his teeth are still there. They're still functioning 25 years later. So in the old days, we could only intrude maxillary and mandibular anterior teeth. But today, with the advent of skeletal anchorage, which is obviously TADs and plates, and the advent of surgically facilitated orthodontic treatment, we can now intrude anywhere from 1 to 14 teeth in an arch. So we're not limited to front teeth anymore, and that has totally changed the way I treatment plan the interdisciplinary patient. Because in the old days, it was all about increasing vertical dimension on the wear patient, because that's the only way we could create room for the restorations, and functional crown lengthening, and furcations exposed, and sensitive teeth, and all the things that went with the way we did dentistry 15, 20 years ago. We don't do it that way very often anymore because we have the ability to move the teeth back where they're supposed to be rather than having to work with them in the positions that they've evolved to through all those years of wear.
Yeah.
So orthodontic intrusion, I'd say, is the most exciting for me of the 6 tools because it's the one that's changed the way we treat the wear patient so much.
Right. Now I'm going to ask you a question too, because this comes up a lot and we're going to get through the rest of the tools. What if I'm watching this and I'm a young dentist and I'm like, Dr. Robbins, that is so spot on, but how do you even start to communicate with your specialist and how did you do that? Like, what kind of advice would you give me to start to work with a specialist in that respect? Do you have any advice on that?
I've got some advice.
Please.
Before you start working with a specialist, you got to pick the specialist.
So what does that mean? Tell me what that means.
So what that means is not every orthodontist in town is into what I'm talking about.
Right.
There are a significant number of orthodontists that enjoy treating children. They don't enjoy treating adults. Adults are hard. It's hard to get the things done sometimes on the adult patient. And so not all orthodontists enjoy treating the adult patient. So when I'm counseling young dentists and they're moving to a new community and they're developing their treatment team, they obviously have to have a periodontist, they've got to have an orthodontist, they've got to have an oral maxillofacial surgeon, probably an endodontist, pediatric dentist. They've got to develop this team. The hardest member of the team to select, in my opinion, is the orthodontist, because you have to find an orthodontist that wants to do what you need them to do. And the orthodontist that just treats the kiddies in your town isn't necessarily the one that you need to do what you need as an interdisciplinary team member. So when I'm talking to young dentists, I tell them that these are the 2 questions I would ask an orthodontist when I was interviewing the orthodontist. Because remember, the young restorative dentist is picking the orthodontist, not vice versa. It's an important point. We're the ones that are picking the specialists that we're going to work with. So these are the 2 questions I would ask when I'm interviewing an orthodontist. The first one is, what percentage of adults do you treat in your practice? Very simple question. And if the orthodontist says, oh, I treat adults in my practice, that's not the right answer. The right answer needs to be at least 25%, in my opinion, and even more than that is better. Because if an orthodontist is treating 25, 30, 35, 40% of their patients are adults, that tells me they enjoy doing adult orthodontics. That's the first question. Mm-hmm. The second question I would ask the orthodontist is, can you tell me about intrusion mechanics in your practice? Now, that's kind of a funky question to ask for general dentists to be asking, but essentially what I'm asking the orthodontist is 2 things. First of all, do you use TADs? Are you comfortable with TADs? Do you use TADs often in your adult patients? Because if the answer is, yeah, we use TADs sometimes, that's not the right answer, because TADs are going to be a very common component of the intrusion that I'm asking for in the adult orthodontic patient. Okay, so I want to know about, first of all, are you comfortable using TADs and skeletal anchorage? And secondly, are you comfortable intruding teeth? Because if the orthodontist is not really comfortable intruding maxillary anterior teeth 3 millimeters in a reasonable amount of time, then that's probably not going to be the person that's going to fit well on my team. So, number 1, you say, what percentage of adults do you treat in your practice? Number 2, let's talk about intrusion mechanics. Okay.
Wait. Now I have one more question though, too, because I get these questions. Can I ask you? So if you have a young dentist who's going through all this training, they're like, okay, Dr. Robbins, I totally get it, but how do I communicate with my specialist? Because sometimes I send things over. Now I won't pick out the specialist, but you can guess. I send it over there and he's like, well, I decided to do this. And you're like, oh no, like, can you speak to that? Maybe not being on the same page. So let's say I do choose the right specialist. How do I communicate with them in a way that we can see clearly where I would like to go with this patient, or maybe we go together? Can you just add some perspective to that?
Absolutely. Traditionally, I'm going to tell you the way I did it traditionally, and that's up until fairly recently, within the last 5 years. Okay. Traditionally, I started with words. So I would just speak with my orthodontist either by phone or by email. I would make the referral. My treatment plan would be attached so the orthodontist knew what the end game was for me, how many teeth I was going to restore, and I would ask the orthodontist to do what I wanted. Let's say, for the sake of discussion, it's an anterior wear case with not much posterior wear. So we're not going to restore the posterior teeth, but we're going to intrude the maxillary anterior teeth. We're going to intrude the mandibular anterior teeth, and then we're going to lengthen them back with porcelain restorations on upper and lower anterior teeth. Okay? Mm-hmm. So I would start off with words, and I would just tell the orthodontist, I want you to intrude the maxillary anterior teeth 3 millimeters, the mandibular anterior teeth 2 millimeters, and when we get close to the end, that's when I want to become involved in finalizing the positions of the teeth. Towards the end of ortho, I would then get the patient in. The orthodontist would call me up and say, Mrs. Jones is about ready. Would you take a look? It's impossible for the orthodontist or the restorative dentist to look at a patient's mouth and know if these teeth have been moved in exactly the right position. It's impossible. You can't tell by looking because they have to be exactly the right length, coupled at a good interincisal angle and a good posterior anterior occlusal plane. You can't see all of that with your eyes. So I would then go in and do some quick mock bonding. So I would add composite to the maxillary anterior teeth, composite to the mandibular anterior teeth very quickly. It wasn't going to stay in place, and determine if the teeth are in the right place, which, by the way, they were never in the right place. So it always then became a dance between me and the orthodontist doing this bonding at the end, trying to find this very perfect position for the upper and lower anterior teeth. It was a very frustrating way to finish the case. So a few years ago, we finally came to realize that instead of doing this orthodontic bonding at the end, mock bonding at the end, trying to figure out the correct position, let's do the mock bonding or the bonding earlier. So today, in almost all of these pre-orthodontic patients, pre-restorative patients that are going to get orthodontics done, we either place composite on the teeth that are going to be restored before the orthodontic appliances go in place or midway through. Sometimes there's no room to place the composite or the teeth are rotated. So the orthodontist is going to spend a year to move the teeth into better positions. I'm then going to go in and place composite in the maxillary teeth, the mandibular teeth, as many teeth as we're going to restore ultimately. Mm-hmm. So if it's going to be a full mouth rehabilitation with 28 units, there's going to be composite on 28 teeth. Okay? And so then the orthodontist isn't guessing where to put the teeth. The orthodontist now has anatomically correct front and back teeth that he or she can then move into a perfect interocclusal relationship so that he or she can see that they're correct and I can see that they're correct. And then it makes the end game so much easier. So today, it's all about intermediate or pre-orthodontic bonding. The other new component is the whole concept of digital smile design, which Christian Coachman has shared with us. And I know pretty much everybody's listening to this knows about Christian Coachman. At least you've heard of him, and you know to some degree what his digital smile design techniques are. So in the last year, I've been incorporating digital smile design into my practice also, which is, first of all, drawing lines, and I don't have to do them. They'll do it at the lab for me. I take the photographs, send them to the laboratory. The lab is going to draw the lines onto the face, the smile. They're going to then take that two-dimensional representation and turn it into a three-dimensional representation, and they're going to provide me with a cast that proposes what the final restorations are going to look like and a stent. And with that stent, I can do a motivational mock-up very early in the patient to give them a preview of what this is going to look like. And if we're going to be doing crown lengthening on the patient, then obviously the stent is going to go up over the gingiva, so the motivational mock-up in the mouth is going to cover the gingiva so the patient can see what it's going to look like at the end. And so that's the other exciting thing. The two things that have changed the way I do interdisciplinary dentistry with an orthodontist are, first of all, we're doing either pre-orthodontic bonding or intermediate orthodontic bonding. And secondly, we're starting to incorporate the digital smile design concepts in not only communicating with the patient, but then communicating the information to the orthodontist also. Very exciting time to be doing dentistry.
Now, it's pretty cool listening to you. I mean, you're crazy excited about the future, too. And you think about the efficiency and the accuracy of those two components and what it's added to the restorative result is tremendous just in the last couple of years, right?
Yeah, absolutely. I'm very excited about it. I love hanging out with Christian Coachman. I
doing
do.
anything. I mean, just hanging out socially, talking about anything. The guy it's just fun to see what he's up to. And one can only imagine what the future looks like here, too.
No doubt. In fact, even just standing next to him, if you hang out with him and stand next to him, you're going to get your photograph taken a lot. Just standing next to him. So what's not to like?
I got to go shopping with him. He's one of the sharpest dressers around. Now, hey, I got to ask this question too, because I get this question too. Who calls the shots on when the bands come off? You're already pointed to that, but I've seen bands come off prematurely in a restorative case. Can you just speak to that too? Because I get that question all the time.
Yeah, that's a pretty easy one. The last person to touch the tooth is the one that's in control of where the teeth go. So unless the orthodontist is doing the restorative dentistry at the end, I'm the one that tells when the bands come off. So, but that's a really important question. I mean, it is a nightmare to have a patient show up at the restorative dentist's office after 2 years in ortho with the braces off, ready to go, because the chances are essentially zero, if there's not pre-orthodontic bonding involved, that the teeth are in the right place. So that's never the deal anymore. And I have 3 orthodontists I work with in San Antonio, 3 and only 3. They're all 3 very talented, and they all know that I want to be involved at the end. I'm always involved at the end and I give the okay before the braces come off.
Well, and the issue's bigger here is you're going to cut a lot of virgin tooth structure that really doesn't need to be cut in order to get where you need to be. Would you agree?
Absolutely. That's the other great thing about doing this diagnosis ahead of time, because then we put the teeth in positions that allow us to do this much more conservative dentistry than we had to do 20 years ago when we were doing 28 units. Yeah, it's a much more conservative time, which makes everybody happy.
Everybody's happy. It's awesome. So cool. Well, let's keep going with the tools. So what's our next tool when it comes to fixing the global diagnosis? Okay.
So we've gone over the 2 perio tools, adding and subtracting tissue. We've gone over the 2 ortho tools, intruding and extruding teeth. That brings us to the 5th tool, which is the surgery tool. And surgery encompasses extraction, implants, and orthodontic surgery.
Okay.
So that's tool number 5 to get teeth and gingiva in the right place. And the final and 6th tool, which is actually fairly interesting and exciting these days also, is the plastics tool. And plastics encompasses Botox, filler, and plastic surgery procedures. So at the end of the day, that's it. That's our only 6 tools to get the landscape, which is the lips, and the teeth and gingiva into the right place. That's it.
Let me go. I'm going to ask you a question about the surgery too. Any quick tips, things that you learned working with an oral surgeon that you would say these are some for sures that I would have you do when working with a great oral surgeon?
You know, the interesting thing about general dentists and oral surgeons is that as a group, we are intimidated by oral surgeons. And the reason we're intimidated by them is because we don't understand orthodontic surgery. Most of us have never spent any time in the OR. We only know about orthodontic surgery based on what we've seen in textbooks or videos a little bit, and we don't really understand the diagnostic component of doing orthodontic surgery. So I would say for a younger, or really for any general dentist that's really interested in doing interdisciplinary dentistry, we need to be more involved in the diagnostic phase of the treatment planning when the oral and maxillofacial surgeon and the orthodontist are treatment planning the patient for orthodontic surgery. It's not that I have a whole lot to add to the discussion, although I do sometimes have something to add, because I know about incisal display and repose and gingival levels to horizon and full smile. I know about all those things that may be overlooked by the other 2 specialists. And so I think the key issue is to be part of the team. And part of the team means you've got to be there when they're treatment planning these patients. The restorative dentist needs to be involved in the treatment planning. Early on, I think that needs to be when we're all together. One of Coachman's big things is to be able to treatment plan a patient at totally different times, because it's so hard to get the orthodontist, the oral maxillofacial surgeon, and the restorative dentist together at the same time. Very difficult to do. So his goal is to set up a systematic approach that allows us to treatment plan these patients, but we don't have to be face-to-face or doing it all at the same time. We just have to have the same language and the same tools.
Right. And let me speak on behalf of some of the specialists that we work with too. do you do this? A big part of this whole thing is a lot of the specialists don't see the finished work because we're so interested in getting them started, getting them going, getting in the right place. Yeah. But is there a way? Give us some thoughts on the completion and having the oral surgeon see where all this end up. What are your thoughts on that?
Well, they deserve to see it.
Right.
I'm as guilty as the next. I've gotten pretty good at making photographs of my nice cases and getting them back to the laboratory, because they're the people that I think are completely left out of this equation. Right. They do the beautiful work at some distant lab bench, and they never have the benefit of seeing the smile of that patient or how beautiful things look. And so I think the lab technicians are the lost souls in this thing, but it's certainly true for the oral surgeons and the periodontists and the orthodontists too. I'm not the best at this, and so I'm a bit guilty at not making sure that I get post-op photographs to the specialist. So I'll take a reprimand on that one, but you're right. They deserve to see what you've done. They deserve to see the patient with a smile on their face, and they may not get to see it in person. So obviously sending photographs is an important part of that. Absolutely.
Yeah, and I'm going to set you up on this question because I know you're going to answer this one, but do you have a favorite specialist?
Yeah, it's the dental hygienist because it's the one I live with.
Other than the one you live with, who's your favorite specialist? Do you have, and give us a thought on that. I mean, you don't have to answer it too specifically, but if you were to answer that in a general term, what would you say?
Well, I guess for me, I mean, this is really a crummy question. So
I know it's a lousy question.
For me personally, the answer is pretty easy. I've got pretty significant perio skills. Yeah. So I can add tissue and I can subtract tissue myself. I've been doing that for years. I have no ortho skills. And so from my personal point of view, the specialist in my life that makes the biggest difference to me day in and day out is the orthodontist. That's the one that has made the biggest change in the way I do interdisciplinary dentistry, because I don't have the skills to do any of that myself.
Yeah, absolutely. I know it's a crummy question. It's like asking which kid is your favorite kid.
Yeah.
Everybody has a favorite kid. They just don't want to admit it. So
yeah. And by the way, my favorite kid knows who she is. So.
My favorite kid is all of my kids. Okay, so let's go into plastics. So on the plastic side, how is that really grown? Because there are some people that haven't completely adopted the plastics, but is plastics a really big deal in the United States in restorative or even around the globe restoratively?
No, it's not a big deal yet, because it hasn't sort of risen to the level of a big deal.
Right.
But certainly it's got the potential to be a big deal.
Okay.
So most dentists don't even think about the sixth tool as a possibility. So it is by far the least used of the six tools in my practice. Okay. I don't do Botox because Jeff's wife, Lisa Rouse, is also a restorative dentist, and she's become very good at Botox and filler. So I don't need to have those skills because she's been doing it for several years, and she does it so much better than I could. So I make a referral to Lisa maybe twice a year for Botox and or filler. That's it. So it's not very often. Occasionally, I make a referral to a plastic surgeon or an oral surgeon for some type of lip revision, some type of lip surgery. But day in and day out, it's by far the least used of the six tools in my practice. But for that one or two patients in a year who has a hyperactive upper lip, hates the way they look, but doesn't want orthodontic surgery, they're not going to get a maxillary impaction, but they don't like the gingival display. Botox is a perfect solution for that patient. So if you have it in your bag of tricks, even though you only use it a couple of times a year maybe, for those two patients, it's giant. So it's an important tool. It's just not a tool that I use as often as the other five.
Yeah, absolutely. Now, again, I'm going to ask this question on behalf of I have a lot of younger dentists watching this. Some of them are fresh out of dental school. We got a lot of kids in dental school who are saying, Dr. Rouse, I understand this. Like, this is stuff I want to learn, but I don't have the money to go to training or anything like that. I mean, where do I start? What would I do? And I'll talk about your course. Obviously, it's a fantastic course, but give some perspectives of these young kids that watch this and how important their technical journey is for a long, healthy, happy life in dentistry.
Well, I mean, that's a dilemma. There's no question about it, because
Right.
good continuing education has a significant price tag associated with it. So when a young dentist gets out of dental school, commonly they're not in a position to pay $5,000 or $6,000 for a 2-day course, because that's essentially what the smaller hands-on courses at the really fine teaching centers are going to cost. So the first thing every young dentist has to do when they get out of dental school, if they want to learn to do higher level interdisciplinary dentistry, is they've got to join a study club.
Right.
So in terms of bang for your buck, a study club like a Seattle study club, that's one group, that's one network of study clubs that I lecture for a lot. These Seattle study club systems, there's, I don't know, approaching 300 of them around the country. So there's lots of Seattle study clubs. That is one great place to go and start to learn interdisciplinary dentistry. In more recent years, there's now a large group of Spear study clubs. So that's another large group of study clubs that you can become a part of. So between the Spear study clubs and the Seattle study clubs, almost all cities have several of these. Larger cities have many of them available. So the young dentist has to join a study club when he or she gets out of dental school. That's the best way to start down the path in interdisciplinary dentistry.
Yeah.
Ultimately, you're going to have a continuing education line item in your budget. So I'm not proposing that's going to be the first year or second year out of dental school, but there's going to be a point at which you can't get it at the state meeting anymore. The state meeting is only to go get inspiration. It's not to learn to do higher level dentistry. So you go to the state meeting to hear people speak, and then you find somebody that really lights your fire, and then you go follow that person and you learn from them. So I think, first of all, my advice would be the study club. Second is to continue to go to the less expensive venues to listen to people speak, but realize ultimately you're going to have a line item in your budget every year for the more expensive continuing education, because that's what you have to do to get there.
Yeah, absolutely. I would completely agree. You think about the study club concept. The world's best educators come to your town, right? And you're working with everybody around you, because dentistry, probably more for males than females, can be crazy isolating at times. I mean, females tend to be a little bit better, and that's a generalization. But think about that. They come to you. And then the second thing is, it's not so much for the information, it's the conditioning of the mind. You got to keep your mind engaged, because when you do, you see possibilities. When you don't, you only see obstacles. And so it's critical. And the things that you're teaching, the things that we see, it's just amazing. You can see these kids when they have the fire in their eyes, because they're lighting the fire and they're keeping the fire lit. So it's critical. And I just, speaking of fires, I always tell my kids, the campfire, we're always making the campfire. And I use that every time I talk to you. I just love, I love all the stuff you teach me. Now, if you're watching this, a couple things. If you have questions for Dr. Robbins, I want you to feel free to ask him. He is amazing at being able to just give great perspective on all of these things. And he also has an amazing course coming up. There's two of them. There's one on November 3rd and 4th in Austin, and another one on December 1st and 2nd on the core treatment planning, which is it's amazing. Now, can you just speak about those, Bill, for a second? What happens during those courses, and why would I want to go as a young dentist, and what am I going to learn?
Sure. It's actually a continuum. So it's set up to come both weekends. That's the way it's set up. It's a Friday, Saturday in November, and a Friday, Saturday in December. One other thing before I talk about it, one other thing I want to mention that comes out of the continuing education is the networking that comes from it. I've had the pleasure of going to 2 or 3 of Dr. Coachman's courses, and holy cow, I've met people literally from all over the world. And if you think the best dentistry is being done in the United States, you go to one of Coachman's courses and you're going to find out that there is some incredible dentistry being done all over the place. In South America, in Eastern Europe, it's amazing what some of these guys and ladies are doing in these places. And so it gives you a perspective, this idea that we're sort of the best and the brightest in the United States. It will challenge that concept a lot. And so going to courses, you develop a network of people that you're going to enjoy being around, in some cases, for the rest of your life.
Yeah.
And it's also a place occasionally that mentorships are set up, mentee mentorships, where you meet somebody, you develop a friendship. It's an older guy, you're a younger guy, and all of a sudden you've now got a mentor. So that's another part of going to the continuing education and study clubs that I think is so important. So my continuum in Austin is essentially about what I'm talking about today. So the first day would be a full day of global diagnosis. The second day would be a full day of the 6 tools. The third day would be the better part of a day talking about dental-alveolar extrusion, because that's the most interesting of the global diagnoses. And it's that day that I talk about vertical dimension. How do you know how to increase vertical dimension? How much can you increase vertical dimension? So there's actually 9 ways that you can treat dental-alveolar extrusion. When teeth have super erupted and gone into wrong places, there are 9 ways, at least 9 ways I've come up with. I always say at the course, if you can give me number 10, I will put an asterisk with your name by it. So far, I've only got 9 ways to treat dental-alveolar extrusion. That's the third day. The fourth day then is more of a wrap-it-up day. We talk about porcelain veneers. We talk about posterior bonded restorations. We talk about practice philosophy, and we end up with some treatment planning. And so that's what the 4 days of my continuum are about. And it's geared for the young dentist. Everybody is invited, but Austin is just a great dental community. Mm-hmm. It's the most inclusive dental community that I've ever been around. And when young dentists come to Austin, the older dentists as a group and as a dental society are very inclusive of the younger dentist. And so they bring them in. They have a new dentist study club. The Capillary Dental Society in Austin has a study club they started just for young dentists. It costs essentially nothing to join the study club, and it's a way to get them involved in the study club concept for essentially very little money. So I love the Austin community, and that's one of the reasons I enjoy doing my continuum there, because there's many young dentists there that my continuum really appeals to, and Austin is a really cool city to visit. So I'd love for anybody that's listening to at least contact Belinda and find out about it. We'll tell you about what's involved.
Absolutely. Amazing city, amazing people, amazing food, amazing education. You can't miss it. So you got to go and check it out. So there's over 16,000 of you that have found this on iTunes. So I'm just going to give you the phone number in case you're listening to this. It's 210-341-4409. So just call that. Dr. Robbins does it the good old way, which is relationship-based way. You get to know everybody and just bring them on in the course. So call them, check them out. So thank you, buddy. I really appreciate you being on. We're going to have you back for so many more other things. And so if you're watching this and you want to hear more different subjects and different things, let us know, and I will be sure to get Bill back. But I appreciate you, buddy. I always enjoy every minute I get with you. And like I said, I appreciate everything. So
thanks, Kirk. You're the best, man. Thanks for having me. I really enjoyed it. It's been fun.
No, you're the best. Stay on for a second. Hey, if you're watching this, thank you for watching. And if you enjoyed this, do me one huge favor and just hit the share button, because we'd love to share this great information with everybody else. And until we see you next time, keep watching the Best Practices Show. Have a great night.